Good evening. It's just about 8 o'clock, and I welcome you to another evening CPD session streamed to you live in Dobbs Facebook group and in our CPD page. This is one of our monthly medical legal talks brought to you by our friends at Dr. Shield. So while waiting for more of you guys to come on board, I'll just show you a little clip from Dr. Shield. Okay, so just a minute or so. So while waiting for more of you guys to come on board.
We're Dr. Shield, and we do insurance differently than most companies. Things like simplifying details so it's easy to understand what makes us Malaysia's most innovative indemnity provider. As a Dr. Shield client, you'll enjoy comprehensive coverage with fewer exclusions. With some insurers, you'll only find out what's not covered when you make a claim. Our policy details are online and easy for everyone to understand. Competitive premiums that don't keep increasing. Many insurers increase their premiums across the board to compensate for losses. Dr. Shield limits the number of doctors insured from high-risk categories, so our premiums start fair and stay fair. Prompt dispute resolutions. We're pro-mediation because settlement and negotiation, instead of endless litigation, is better for everyone. Career and reputation protection. Typically, litigation can drain a doctor financially and emotionally. We limit the damage by both, so our clients emerge good names intact. And peace of mind, because a happy doctor is a good doctor. Our different approach to creating policies means we put you first, before us, so you can enjoy your career and sleep like a baby, even if you've just delivered one. Dr. Shield, insurance with a difference.
Okay, that was the blurb from Dr. Shield. So tonight, I'm very pleased to introduce our speaker, Mr. Sridhar Sundaram, who is in the screen below me. Sridhar, hi.
Hi.
Okay. Now, I would just like to go through some housekeeping points first. I think those of you who have attended our previous CPD sessions would know the drill. But basically, we would like the Q&As to be at the end of the talk, and we'll be using Slido as the preferential place where you ask the questions, and then we can answer your questions there. So go to slido.com and enter the code 32244, or you can scan with your barcode scanner and it'll take you to the Slido site. Or you can, if you're watching at docs.my/cpd, the Slido is embedded in the page. Okay, and then we will present the actual QR code for CPD points in this place at the end of the talk. Okay. All right. Now this is going to be a pre-recorded talk. I'm afraid there's a slight glitch. The audio quality was not quite up to what we hoped it would be. So, but if you have anything you want to clarify, you can ask Mr. Sridhar at the end of the talk. But I think it's mostly okay. Just we just apologize. The audio quality was not up to what we hoped it would be. Okay, so here goes the pre-recorded talk. It's about 30 minutes. Okay, and the topic is on a very interesting one, and it's actually challenges doctors face in light of the changing legal landscape. So, and this is actually Mr. Sridhar has actually gave his presentation just audio only, so it's him speaking. So please pay attention.
Good evening. Thank you for taking your time to tune in. My name is Sridhar Sundaram, and I've been a litigator for 26 years, practicing in various areas of law, including medical negligence. Having a number of doctors in the family brings this subject closer to my heart, and I hope that by giving this talk, I can help more doctors be aware of the current standards demanded of them by the courts, so that they can navigate their way safely through the legal minefield that modern day practice has unfortunately evolved, or perhaps evolved too. I'll be happy to take any questions you have at the end of the session. And if you would like a summary of the session emailed to you, or if you have any further clarifications you might need, or even legal advice, I will be pleased to offer a 2-hour free consultation. Just WhatsApp me on 017-888-4759. Now, the topic that we are discussing today, and I hope I don't bore you to tears, is challenges doctors face in light of the changing legal landscape. Now, right at the outset, let me make it clear that in law, a doctor's responsibility to his patient is broken down into 3 lids. Firstly, diagnosis. Secondly, advice. And finally, treatment. Now, many doctors believe that as long as the diagnosis of the patient and the treatment of a patient is not flawed, and that means it meets the approval of their peers as experts in a court of law, that they cannot be held liable for negligence. Sadly, this is not true. I'll just quickly refer to the case of Chester against Ashfar in 2004. It involved a failure to warn a surgical patient of the 1 to 2% risk of cauda equina syndrome. The operation was not carried out negligently. Nevertheless, the claimant's case was that if she had been warned, she would have delayed the operation to reconsider and take a second opinion. Now, giving judgment in her favor, Lord Stein said that in modern law, medical paternalism no longer rules, and a patient has a prima facie right, informed by a surgeon, of a small but well-established risk of serious injury as a result of that surgery. Here in Malaysia, we have the case of Dr. Hari Krishnan and another versus Megat Nor Ishak Megat Ibrahim and another, where the federal court affirmed the award as the award of RM 200,000 as general damages. That's not a lot, but it also awarded an unprecedented sum of 1 million as aggravated damages, and that has caused shockwaves in the medical fraternity. Now, we're not going to discuss aggravated damages tonight. Hopefully that will be a topic for another day. So what we have here is a decision by the highest court in the land, reiterating the latest evolution of the position of the law in Malaysia with respect to the standard of care for medical professionals. Earlier on, I said diagnosis, advice, and treatment. So here what the the federal court has said is, for diagnosis and treatment, the court must accept views of a responsible body of men skilled in that particular discipline, cannot resolve differences of expert opinion on its own. However, it must still examine the expert evidence to see if it's capable of withstanding logical analysis. The court then went on to say, as for the duty to advise of risks, it is the courts and not the body of medical professionals who decide the yardstick for the standard of care to be effective. Now, you will, of course, see this dichotomy here. For diagnosis and treatment, the court will, in most instances, accept what the medical fraternity has to say about it. Insofar as advice, i.e. the duty to advise of risks, the court will step in and it will substitute its own judgment. Now, how did this happen? What does it mean to you as medical practitioners? Actually, we're going to have to get a little bit legal here, and we'll touch on the topic of development of law with regards to medical negligence. Right up until 2015, rather than enter the medical arena and supplant their judgment for that of doctors, the court would judge the adequacy of information disclosure in medical negligence claims by asking whether the doctor's conduct would be supported by a responsible body of clinicians. Now, this is called the Bulletin Test, and I'm sure you've heard about it before. Now, the qualification with the Bulletin Test is that the court considers this professional opinion to be reasonable and logical. This test was applied to 3 aspects of the doctor's duty i.e., as I mentioned earlier, diagnosis, treatment, and diagnosis, advice, and treatment. Now, that was the traditional way of looking at things. Fortunately, in 2015, this familiar legal standard was redefined by the Supreme Court in the UK in the ruling of the famous case, well, now famous case of Montgomery against Lanarkshire Health Board. Nadine Montgomery, a molecular biologist with a type 1 diabetes and with a relatively short stature, gave birth to her son, Sam, by vaginal delivery in 1999. Labor was complicated by shoulder dystocia, which resulted in a 12-minute period of acute hypoxia. Sam being born with cerebral palsy and traction-related Erb's palsy. Montgomery sued for negligence, arguing that she would have requested a cesarean section had her obstetrician informed her of her personal 9 to 10% predicted risk of shoulder dystocia based on known factors. The Supreme Court ruled in her favor and declared that doctors should ensure patients are aware of any risks material to them and also any reasonable treatment alternatives. The materiality of risk was defined as whether a reasonable person in the patient's position would likely to attach significance to the risk, or the doctor is or should reasonably be aware that the particular patient would likely to attach significance to it. In the post-Montgomery era, the belief that there was a percentage threshold of improbability below which a risk need not be disclosed is now updated. Consent discussions must now be tailored to the physical, emotional, and spiritual needs of the individual patient to identify which risks could hold significance, and it is premised on the following principles. They are as follows. Right to accept or refuse treatment is a basic human right. The doctor has a duty to inform the patient of the material risk, and the onus is not on the patient to ask. The threshold is lower for those who lack knowledge or express anxiety only in more general concerns. The doctor has a duty to provide sufficient information for the patient to make an autonomous decision. Frequently occurring but less serious outcomes may be as important to the patient as serious outcomes of which the risk is small. The doctor has a responsibility to explain which is the medically preferred option and why. The doctor must not assume that the patient is medically uninformed or incapable of understanding medical matters. Whether a risk is material or not, whether a risk is material is to be judged by what a reasonably prudent patient in the situation of the patient would regard as a significant risk. A material risk is not a matter of clinical judgment. The patient is entitled to take into account non-medical matters, circumstances, objectives, and values. And lastly, the doctor must respect the patient's decision, even if it is not the medically preferred option. What Montgomery has made clear is that the duty to discuss risk goes beyond the duty to discuss known risks. That is to say, there may be factors of importance to which the patient, which if discussed, would affect their decision-making. It is clear that this process is one which involves dialogue. I can see some of you sort of rolling your eyes. We all know that you're terribly busy, and it takes a long time to explain risks and benefits to a patient. But under Montgomery, that is, to not do so would be to cause disaster. Because unless all information is given to the patient, the healthcare professional potentially deprives the patient of key information to make a properly informed decision. For that reason, Lord Kerr specifically noted whether a risk is material cannot be reduced to percentages. Only a patient can decide what is an acceptable risk. It is important to note that the requirement to provide adequate and complete information extends throughout the care. In the case of Gallardo against Imperial College Healthcare in 2017, the court had to consider whether there was an obligation to provide full and complete information after the conclusion of the treatment. The claimant had been in intensive care and was therefore too unwell to discuss matters preoperatively. It was found that further information should have been provided. The claimant was not advised post-operatively about his malignant tumor, such that his subsequent treatment under other clinicians was considered suboptimal. Now, I'll just take you quickly through some of the practical implications of this Montgomery test. Under the Montgomery test, their lordships drew attention to three important points. First one is whether the assessment of, firstly, the assessment of whether a risk is material cannot be reduced to percentages. I've said that before. Significance of a given risk is likely to reflect a variety of factors besides its magnitude. For example, nature of the risk, the effect which its occurrence would have upon the life of the patient, the importance to them of the benefits sought to be achieved by the treatment, the alternatives available, and the risks these involve. The assessment, therefore, is fact-sensitive, sensitive also to the characteristics of the patient. So, for example, if you're treating a model, then even if the chances of scarring are low, because she is a model, you need to take that into consideration. Secondly, the doctor's advisory role involves dialogue, the aim of which is to ensure that the patient understands the seriousness of her condition and the anticipated benefits and risks of the proposed treatment and any reasonable alternatives, so that she is then in a position to make an informed decision. This role requires the information provided to be comprehensible. The doctor's duty is therefore not fulfilled by bombarding the patient with technical information that she cannot reasonably be expected to grasp, let alone by routinely demanding a signature on a consent form. Thirdly, it is important that the therapeutic exception in this rule should not be abused. I will explain further later. So what it says is, thirdly, it is important that the therapeutic exception should not be abused. It is not to permit a doctor to prevent the patient from making an informed choice where she is liable to make a choice which the doctor considers to be contrary to her best interest. Now, I have shamelessly purloined a flowchart that was created by Colin Liu and Tham Li Jing in their article, A New Test for Medical Negligence. It's called the Montgomery Test, and it illustrates the legal hoops through which doctors are now expected to jump through in order to avoid the long arm law. Just give me a second. Okay, I hope you can see the medical negligence flow chart. I'm going to have to take you through that. Okay, you can see on the chart, the extreme left, in sort of orange color, you have the complaint. And as I mentioned earlier, a patient's, as a doctor, your duty to the patient is divided in parts: diagnosis, treatment, advice. Now, we're going to leave the diagnosis and treatment out. From complaint, you follow the route straight down to advice. And the first thing the court is going to, the first test the court is going to apply is stage 1 of the Montgomery test. Was relevant and material information not communicated to the patient? If that is not a problem and relevant and material information was communicated, you're fine. So then you go up to no, and straight away the arrow leads you to not negligent. If relevant and material information was in fact not communicated to the patient, then you move on to the next stage of the test, which is the Montgomery Test stage 2. Was the doctor in possession of that information? Now, if the doctor was not in possession of that information, then it takes you back. You're back in the same situation as diagnosis. That's why the arrow takes you back up to diagnosis, and the age-old test of Bolam is applied. So if your peers agree with you that that information is not something that you be expected to be in possession of, then you're held not to be negligent, and again, you're off the hook. However, if you were in possession of that information, the question then arises, why did you withhold it? That takes us to the stage 3 of the Montgomery test on the extreme right. Was the doctor justified in withholding the information from the patient? Now, if you are justified in withholding that information, again, you're held not to be negligent. But if you can't justify why you withheld that information, despite the fact that you were in possession of it and that it was relevant and material information, then according to the Montgomery test, you would be held liable for negligence. Okay, we're going to move on now. And we're going to discuss the approach that doctors need to take in practice in order to stay on the right side of the law. Now, thousands of doctors engage in complex discussions with their patients to identify which, if any, treatments to pursue. Central to each of these discussions is the notion of informed consent, whereby the doctor discloses material information, treatment, or procedures, and facilitates understanding so that the patient can decide which option they favor. Consent discussions must navigate the interface between beneficence, non-maleficence, and patient autonomy. That's a very delicate balance. It's a considerable challenge in a time-pressured healthcare setting. Facilitating good understanding of the indication and nature of treatment can improve patient satisfaction and preoperative anxiety levels. In contrast, failing to engage patients in the consent discussion can lead to a loss of trust and heightens the risk of litigation in the event of post-operative complications. In the UK, we have the Good Medical Practice by the General Medical Council, known as the GMC, which in 2013 states in its duties of a doctor, work in partnership with patients. What the GMC advises is listen to, respond to the patient's concerns and preferences. Give the patients the information they want or need in a way they can understand. Respect the patient's right to reach decisions with you about their treatment and care. It then further goes on with regards to consent, patients and doctors making together. It describes a basic model of partnership between doctors and patients. Doctor explains the options to the patient, setting out the potential benefits, risks, burdens, and side effects of each option, including the option to have no treatment. The doctor may recommend a particular option which they believe to be best for the patient, but it must not put pressure on the patient to accept their advice. Give me a second here. The patient then weighs up the potential benefits, risks, and burdens of the various options, as well as any non-clinical issues that are relevant to them. The patient decides, not the doctor. So you're moving from a doctor-centric situation to a patient-centric situation. The patient decides whether or not they accept any of the options, and if so, which one? In relation to risks, it advises that the doctor must tell the patient if the treatment might result in serious adverse outcome, even if the risk is very small. Conversely, it must also tell the patient about less serious complications if they occur frequently. A national cross-sectional questionnaire study of 550 was conducted in the UK. 81% of doctors were aware of the recent changes in consent law, yet only 35% reported a noticeable change in the local consent process. Important barriers to modernization included limited consent training, a lack of protected time for discussions with patients, and minimal uptake of technology to aid decision-making or documentation. 47% of respondents in this case had received no formal training on how to approach it. And research from the USA has shown that informed consent training programs improve surgical trainees' knowledge and confidence in the consent process. So this is something that hospitals and owners of clinics look at. Royal College of Surgeons, RSC, outlined 4 broad principles which surgeons should adhere to. Surgeons should tailor discussions to the individual patient by allowing time to get to know them well enough to understand their views and values, explain all reasonable treatment options along with their implications, discuss material risks for each of these treatment options, and keep written documentation of the discussion in an signed consent form. Now, I would have thought that this doesn't apply just to surgeons, but all medical practitioners. There is a new, or rather alternative approach that could be developed as, there's a call to develop a repository of patient decision aids, PDAs, in the form of evidence-based interactive websites with embedded multimedia, example graphics or videos. A Cochrane review reported that PDAs helped patients to gain knowledge about a procedure, improve understanding of benefits and potential risks, facilitate decision-making, and promote patient autonomy. By presenting information enhanced with pop-up definitions of medical terminology and links to more in-depth information, patients could tailor the level of disclosure to meet their own values and information needs. They could also have the opportunity to review information on multiple occasions before completing a quiz to assess comprehension. A transcript documenting any area of misunderstanding or items flagged as being of particular importance to the patient could facilitate a later face-to-face discussion with the designated medical practitioner. By helping patients to arrive well-informed, PDAs could save time in clinic appointments, allowing medical practitioners to address any personal beliefs or concerns regarding treatment in depth. Printed formats of PDAs should be made available for those without access to internet-enabled devices. Now, if despite your best efforts, the worst happens, how do you then best mitigate the ensuing fallout? Now, these are my observations from my own personal experience in dealing with cases of medical negligence. Please engage the complainant. Don't avoid or summarily dismiss complaints. Adopting a defensive or evasive stand will almost always escalate the situation. But that doesn't mean that you should admit fault. Please do not admit fault or offer compensation without legal advice. Further, just by taking time to listen to the patient's grievance and offering some explanation and advice or assurances, as well as being sympathetic, goes a long way to diffuse a potentially explosive situation. Sometimes the patient just wants to rant. Now, even if you have been negligent, you're less likely to be sued. Or even if you are sued, you're more likely to be able to amicably settle out of court If you are perceived to be an approachable, understanding, and genuinely concerned about the patient's well-being, so those few extra minutes you spend entertaining a complaint, no matter how trivial or unjustified it might be, may ultimately save you countless sleepless nights and months of expensive litigation. Not to mention lots of profit for having to close your clinic, to attend briefings, mediations, and trial dates. Not to mention the loss of reputation. If the claim is intimated, please notify your insurer or broker without any delay. Remember that once it has been filed, even if it is withdrawn or settled out of court or successfully defended against, it may nevertheless result in a huge increase of your insurance premiums. So if you can, nip it in the bud by just spending a little bit more time with a disgruntled patient. Now, what can you do to minimize the risk of litigation? Too many times I hear doctors tell me that they had, in fact, advised the patient of all the pros and cons exhaustively, but due to time constraints, they didn't note it down. Now, sadly, as far as the courts are concerned, if it wasn't written down, it wasn't done. How do you get around that? You have to document everything. I know you're tight for time. You can't write everything down. Get the patient's permission to use electronic audio or video recording equipment. Explain to them that the session is being recorded for both your benefits. And then if anything goes wrong, you can always fall back on your audio video recording. Don't rely on standard printed consent forms. The use of procedure-specific consent forms can reduce variability in documentation of complications, avoid omission of relevant operative risks, improve patient recall, and would be expected to reduce documentation time. Don't leave the task of consent taking, advising of information or warning to nurses or juniors. If possible, have an attending nurse or junior sign off as a witness to your consent forms. And to conclude, for medical practitioners, perhaps the way forward might lie in noting the reasoning in He Chi Kok against Ui Peng Jin and the National Cancer Center by the Singapore Court of Appeal, which adopted a modified approach of the Montgomery Test. It involves a three-stage process in assessing whether the standard of disclosure had been met, with each stage viewed from the perspective of the court as the ultimate arbiter of such disputes. So, in a way, what you're looking at is what would a disgruntled patient need to prove against me in a court of law? And by thinking about that, you can then make sure that you don't fall into that category. So, in order to succeed in a claim against you, the patient would, first of all, have to prove, first of all, the patient would have to identify the exact nature of the information that was alleged had not been provided. Then the patient would have to establish why that information was relevant and material. Now, if that criterion is met, the court then has to determine whether the doctor was in possession of that information in question. Thirdly, if the doctor did possess that information, the court would then examine the doctor's reasons for withholding that information in order to determine whether the non-disclosure was justified. It's the very narrow grounds on which non-disclosure can be justified. It would be if, for instance, by giving that information to the patient, you would actually cause that patient more harm. For instance, if you had a geriatric patient who was extremely anxious to the point where, even though they understood the nature of the information being given to them, but their decision-making process was impaired, and they would not accept a very simple, safe procedure that is obviously going to be very, very beneficial to them. And you'd have to be able to persuade the court that had you given them that information, it would have been detrimental to them. So you are acting in the patient's best interest by withholding that information. As you can probably guess, very, very narrow ground. Not a closed set of factors. Each case would be its own facts. This, however, raises the interesting point, and I'm going to leave you with that. Even if the doctor was negligent in not possessing that information in the first place, would the patient's choice of treatment have been any different had it been disclosed? That might be an interesting argument to take up in court, and I hope none of you end up there. That's all I have for this evening, and I hope that you will let me have your questions, and I'll do my best to answer. Thank you very much.
Okay, we are back, and thank you for the great talk, Sridhar. Slight audio glitches, but I think most people can hear what you did say. Now, I posted the text of the document to which Mr. Sridhar gave his talk on. It's linked in the Slido comments, so you can copy there and you can view it. All right, now I'm going to go on to the Q&A. So there's some questions already. One question rather, from Anonymous. Please put your name as well if you would like us to address you. So Anonymous asks, when taking consent for a surgical procedure, is it important to inform the patient of complications of anesthesia? Who has the duty to obtain this consent? So I presume this question is being asked by a surgeon. Should the surgeon also inform the patient of anesthetic complications rather than the anesthetist himself or herself?
Right. I think that that would be within the field of the anesthetist. Anything to do with anesthesia would be in the within the jurisdiction of the anesthetist. I mean, he or she would be the specialist in that area, and the surgeon should be able to leave it with the anesthetist.
But I guess the anesthetic complication should also be part of the informed consent, isn't it?
Yeah, but the doctor would be, the surgeon would be concentrating more on just that within his sphere of expertise. I would have thought that anything to do with anesthesia would be within the anesthetist's field of expertise, and therefore the anesthetist would be responsible for that. I suppose it wouldn't hurt for the doctor, for the surgeon to also cover it, but seems like a little bit of a...
Yeah. So I hope that answers your question. There is a comment on Facebook, not Slido, which I'll pop the comment. I'll pop the comment up here now. It's very big. From Dr. Lim, has the 2013 High Court case below been further clarified? It requires spouse consent even when a sound patient has refused to follow medical advice. Similarly, consent of the spouse may be required when it's evident that the patient is dependent on the spouse to make decisions in regards to the proposed medical treatment, or when it is evident to the doctor that the decisions are made jointly by both.
Well, not. I have to admit, I haven't seen any further development of that case. But Dr. Lim, I will certainly look up to see whether there's any development in that area. and get back to you if you were to drop me a line.
I think, let's say, if the patient is female and then opts for a gynecological procedure, but the husband's consent was not taken, would how, how important is it in this day and age? Now you need spousal consent as well. And what I'm not sure what you mean by the patient is dependent on the spouse.
Yeah, I don't quite get that as well. As long as the person is mentally capable and of age, they should be the ones who are giving consent, not anyone else.
Yes, but here I think the court has ruled that the spouse consent may be required.
Is refused tomorrow. Requires first spousal consent, even where the sound patient has refused follow medical advice. Okay, I have to admit, I'm not familiar with that case. I really need to look up that area of law. Thanks for bringing that to my attention, Dr. Lim. That's very interesting.
I think spousal consent was a bit controversial when it came up. If I remember vaguely, it was a gynae case, and then I think husband was not pleased that something was not done. I may be mistaken. Okay, Dr. Goh has made a comment that there is a separate general anesthetic consent form. So yeah, okay. Thank you for your comment, Dr. Goh. Okay. Let's see, there's anything coming up in Slido? Yes. All right, there's a question and comment. Sometimes it takes convincing to get a consent. Would it be better to put the fact to allow the patient to decide? Can the doctor be liable for not trying hard?
Okay, that's a very gray line, and that's one of the reasons why I said perhaps you should have audio-video recording, then people can view it, and it's quite clear how far you went in giving your advice, i.e., you gave all the risks and benefits, you made all the risks and benefits apparent, and then did not pressure the patient. But I don't think you can be liable for not trying too hard. I mean, you have to make sure the patient understands the information given to the patient. You can't just bombard the patient. You can't just throw leaflets at them. So the information that you give to the patient has to be at a pace that particular patient can understand. So you have to kind of put yourself in the shoes of the patient as best you can, and try and make the patient understand. That doesn't mean that you can be held liable if, despite your best efforts, the patient does not understand. The court will only look to see whether or not your efforts were reasonable. That's the best you can do. I hope that answers the question.
I think he's trying to say if we weren't convincing enough and the patient did not opt for the procedure, could we be liable? On the other hand, it can be somewhere the other way around. I mean, this is very subjective, isn't it? When we give informed consent, you can spin things in different ways. You can make something sound very dangerous, or you can make something sound very optimistic, depending on how is a cup half full or half empty, isn't it? I mean, it boils down to that.
So yeah, that's why the court has said that, first of all, you have to work out from the patient what it is the patient wants. Then you, as the doctor, have to decide whether that is information that the patient would need. You can't wait for the patient to ask questions. You have to make the patient as well informed. But I don't think you can be liable for not trying too hard. You can lead a horse to water, but you can't make it drink.
Okay, let me give you an example. As a hematologist, sometimes we have difficulty convincing patients to undergo a bone marrow biopsy, which is by and large a very safe and simple procedure, and if done properly is relatively painless. People are afraid of pain and so on, and say usually nothing happens. The only risk may be a little bit of infection if you don't keep the site clean, bleeding minimal. If you really press, you should stop bleeding. Okay. Will you die from a bone marrow? Answer is yes. There is actually a mortality risk of 1 in 50,000 Actually, I came across it when there was a report where a Russian hematologist was jailed. Jail actually in Russia when the patient died after a bone marrow biopsy, which was, and the death was several days later, and it was alleged that it was a result of the bone marrow biopsy, and post-mortem was a bit controversial. But there you have it. She was actually jailed, but actually it can die, but it will be extremely rare. But the should we now, if I were to tell every patient you could die from a marrow, it is 1 in 50,000. Now people have no idea what 1 in 50,000 is. You know.
Okay.
You know, but if I tell a patient you could die from a marrow, nobody is going to have a marrow.
Well, then that's up to them. In the Australian case of Rogers against Whittaker, the patient was blind in one eye and was not warned of the possible 1 in 14,000 risk of surgery on her bad eye, causing sympathetic ophthalmitis, which in turn might cause blindness in her good eye, which unfortunately developed. And the court still held the doctor was negligent in not telling her that 1 in 14,000 risk, because she already had one bad eye. And then, the risk would then be that she'd lose her other eye. So even though it's 1 in 14,000, because of her particular situation, the doctor was held liable for not telling her. So you have to draw your own conclusions as to whether or not you should tell them the risk of dying is 1 in 50,000. I think you can't be faulted for saying that. Whether that's going to scare the patient away, well, that's
inevitably it will. Already they have doubts and fears, and you tell them you could die. It's only 1 in 50,000. You know.
Yeah. So you then have to convince them of all the good things about the operation.
Anyway,
what if you don't have the operation?
You can just go on and on like that. But anyway, this is the
patient understands that if they don't do this bone marrow transplant, then what are all the other bad things that can happen to the patient? And the patient gets a chance to weigh this 1 in 50,000 against all the benefits that they might have, and then they have to make up their mind.
Yeah. For certain procedures, like say bone marrow transplant for leukemia, when you try to save the patient's life, if you don't do it, there is almost 100% chance you will die of the leukemia.
There you go. That's what
if you do it, there is a 10 to 15% chance you could die during the procedure. But on the other hand, where the differences are very stark. But I'm just saying, when the risks are very small, not just like the retinal case, but even in the procedure, but almost everything, there is a finite death rate. But do we tell them? You do a stress ECG, there's 1 in, I think, a few thousand cases you could drop dead during the stress ECG. And does everybody take that in an informed consent form? You could die during the stress ECG. I mean, I don't think any of my colleagues would say you could die during the bone marrow and the risk is 1 in 50,000. I doubt any of my colleagues are currently taking that as part of the informed consent. So I think all these demands of telling every possible risk, no matter how minute, is really has issues in terms of practicality and in terms of acceptability in our culture and our patients. So I think I hope that the court will take that into account.
Right.
Sometimes a colleague of mine recently shared that he was going to do a marrow on a patient, but realized he didn't look so well. And it turned out that he had a heart attack. The patient had a heart attack. So if you had done a marrow and then the patient had collapsed during the procedure, then you would say your marrow killed him.
And he would be then accused of taking a paternalistic view, which is what the court is saying you can't do.
Yeah. Anyway,
the other thing to think about is if all doctors actually gave these sort of didn't give this excuse and just said, look, you could die, but it's a very small chance. Then the patient goes to another doctor and he says the same thing. You're going to get desensitized. It's going to become, every doctor is going to tell you can die from this, but you need to do it.
You know what happens or not? The patient, if you work long enough as a doctor, you realize the patients will keep on going round until they find a doctor who says what they want to hear. And then they'll get a treatment which they feel acceptable. Anyway, that's the day and age where it's patient-centric, so be it. Anyway, let's go on to the other question. Kuharaj asks, has Montgomery been applied in Malaysia in a medical legal case so far?
Yes, it has. Yeah, the case I mentioned right at the beginning. I mentioned the case, or the federal court case of Dr. Hari Krishnan. The principles in Montgomery were reiterated in Malaysian jurisprudence. So yeah, it does apply in Malaysia now. And it applies in medical legal cases, yeah, obviously.
And he asked about the federal court in Zulhasnima in 2017. So I'm not sure we know.
Yeah, that's the thing. I tailored the talk more for doctors rather than lawyers. So we didn't get too much into the local cases. We're looking more at how doctors should respond to the challenges rather than minute on different case law.
Murali asks, if the patient asks for a discount on the fees after a surgical complication and it is given, is that an admission of guilt?
Whether it's an admission of guilt or not, it will be used as an admission of guilt. So not a good thing to do.
Very difficult. If it's called in, you try to be kind and help the patient, also you get hammered.
Yes. Leave that to your insurers to give them a settlement rather than you give a discount and then get yourself into trouble.
Kathleen Lim Kwan Ju asks, Kathleen Jones versus Royal Devon Trust, where the experience of a doctor needs to be made known to the patient as well. What is the status now?
Yes, that still remains, and the patient has a right to know whether she's getting a particularly experienced doctor or not. And if at the last minute there's a change, then she can complain that she is again been denied of her right to that particular doctor. So that position maintains.
Okay, thank you for the question, Dr. Lim. Dr. Yu asks, is it mandatory to explain even very remote complications related to treatment delivery? Example, remote complications with administration of vaccines.
Right. Again, it comes back. You don't have to tell the patient every single risk. If it is a big risk and that particular patient's characteristics would make the patient more vulnerable to that risk, then absolutely. So you have to base it on the patient's history and the patient's characteristics. There's no one rule fits all.
Again, maybe it boils down again to how we explain and the experience, and also sussing up the patient's understanding of things, isn't it?
Yeah, that's the age-old question. Do I tell them every single risk? You have to decide based on your clinical study, patient's history, dialogue with the patient, what is relevant, what is not.
Oh, I think the same question Murali asked. Okay, Varan asked, in pediatric cases, if parents have different opinion, mom agrees, father doesn't, and I think that this is not just in pediatric cases, also in even adults too, because we have family members with differing opinions. So how to proceed? Whom do we listen to? So in this case, the mom and father would be the parents, and there's a child who is not of legal age to give informed consent.
Okay, I'm going to have to get back to you on that one. I never thought of looking at that point of view. That's a very interesting point as well. Dr. Varan, if you drop me a line, I will research that point and get back to you.
How can they contact you, Mr. Sridhar? Shall I put your number there? Would it be all right?
Yep, absolutely. Yeah, please do.
I will, based on your talk, you mentioned your number. You can WhatsApp.
I did. That's correct, yeah.
Is that all right with you if I put there? So I think there's some follow-up questions. You can WhatsApp Mr. Sridhar. It is number. Okay.
Yeah, that's correct.
Can WhatsApp him at 017-888-4759. But be reasonable. Don't disturb him at where he should be.
We're like 7-Eleven. We open all the time. Yeah,
same here. Okay. Would the father actually be the final decider? Generally, would courts decide the paternal one? Have
I can't
precedence
imagine.
over the mother?
I can't imagine why the father would carry more weight than the mother. To be honest with you.
Okay, in this day and age too, where there's, don't know. Anyway, sensitive area. I don't think I'll go
think
into that.
parents would have to make up their minds and not keep. I mean, I need to look at that point.
Okay. Good question, Varun. And Dr. Han asks, the patient died after a bone marrow biopsy due to a punctured femoral artery, a real MOH case.
I think that's directed more at you than me, doctor.
Yeah, actually, I'm aware also of a previous case at another teaching hospital where the patient had very, very soft bone. So the doctor who did the bone marrow just could not control the needle, and he went in. Actually, if you go, the needle goes in too deep and really goes in deep, you could shear the pelvic veins. So you can actually very rarely puncture artery. What happens actually, you puncture the veins and then the patient bleeds slowly. You don't realize it until patient develops hypotension later and so on. It can happen. It is very rare, and this would probably be, that's the reason why there is a mortality of something like 1 in 50,000. Nowadays we do marrows from the pelvic bone posteriorly, so that bone is very thick, so it's very hard to puncture right all the way through. In the old days, we used to do more sternal punctures, where we put the needle right at the breastbone. And you can imagine how thin the breastbone is, and below the breastbone is the heart and aorta. So if you really puncture right through, then you could puncture the aorta and you could get a disastrous bleed. That's why when you do sternal punctures, we have a guard to prevent it from going too deep. But that's very rarely done nowadays. So we do marrows from the posterior iliac crest, so that's much, much safer. Okay. Many accidents also happen. Perhaps if you give sedation, you don't watch the breathing, the patient becomes hypoxic. So some I know that Singapore, I think they don't like their junior doctors to do bone marrow with sedation, which is actually can be quite not a very comfortable procedure for the patient. So everything carries some risk. Okay. The next question, and Dr. Lim Kuan Ju asks again, I think there was a case where a patient was sued for being given too much information that she can't decide. It's a lose-lose situation. We don't give enough, we run into trouble. We give too much, we run into trouble. What do you say?
Honestly, I don't envy being a doctor. I can't recall any case where a patient can sue for being given too much information, because where's the negligence there? I mean, did she make the wrong choice? And I don't know what the facts of the case are. I have never heard of a case where a patient sued for being given too much information that she can't decide. I can't see how that would happen.
What if we are told we gave so much information, the patient was scared of the proper treatment and then decided to go for alternative, and because of the doctor giving all sorts of information which made me so scared, I did not go for the surgery or the proper treatment, and then I went for the alternative instead, and then as a result my cancer became more advanced because it didn't work, because the doctor said I could die from this chemotherapy, I could get this side effect from radiotherapy, etc. So therefore, he scared me. What do you think?
I think she'd have an uphill task to prove if that was the line that was taken. To complain that too much information was given to you. It'd be different if, because of too much information, she then took the wrong option. That she wasn't given information in a way that allowed her to evaluate what the best option was. That's different. And then she chose the wrong option with that. Then she suffered injury. That's different. But it's a fine line. How do you prove? I mean, where do you draw the line? At the end of the day, I think you've just got to be reasonable. If the court finds that you acted reasonably, that the information that you gave was reasonable, then you should be all right.
Okay.
That's a reasonable man test, yeah.
Reasonable patient is the basis for a level of knowledge to convey to the patient. what features a reasonable patient? What are the features of a reasonable patient? Does the
Right.
same standard apply to all? Yeah.
No, it doesn't apply to all. It certainly doesn't. So that's what they meant about getting into a dialogue with the patient. If you're dealing with a very well-educated patient, then it's much more easy for you to explain to the patient the risks and benefits. If, on the other hand, the patient is challenged in that aspect, then you've got to take more time to explain to the patient. End of the day, will the court view your efforts as being reasonable? That's the test.
Okay. It's 9 o'clock. It's come to the end of our session now. We had a very interesting Q&A. So thank you for all your participation. So here comes the moment everybody is waiting for. That's the QR code, which will enable you to get your CME point. So in case Mr. Sridhar doesn't know, we get points by scanning this code. So it's uploaded digitally to the MMA, and then they get CBD points accredited instantly. So please let me know if it's successful. All got your points? Marianne says, thanks, Mr. Sridhar, for the very interesting and informative session. Thanks, Marianne.
Thanks for listening in. Appreciate it.
Yeah.
Do contact me if you need any clarification.
Yeah, I'll show Mr. Sridhar's contact again. You can WhatsApp him on 017-888-4759. Okay, if you have any questions pertaining to the talk. All right. Mr. Sridhar is happy too, but don't abuse the number. Thank you. So all got your points? Okay. Manoharan says thank you. All right. The QR code will be valid for about an hour. So even though we end the talk, we can still play back the video until this point, and you can still scan. After the hour is up, then the code will no longer be valid. All right. Okay, I think we'll probably end the live stream here. So I'd really like to thank Mr. Sridhar for his entertaining talk, and then thank all of you for watching and your interesting questions. I'm sure there are a lot of controversial issues, some of which we didn't touch on, but I did talk to Mr. Sridhar earlier on about recording, video recording, and etc. I don't know how many of you do it, but it's a double-edged sword as well. And other things. You got anything else? Feel free to discuss in our forums, or you can text Mr. Sridhar if you had some need clarification. Especially there were a few unanswered ones. The one about spousal consent, and the one about where mother and father disagree, and who takes precedence. I think those are interesting questions, and I'm not sure what the answer should be, but perhaps it can be enlightened in a future session. Okay, so I'm going to end the broadcast. So thank you, everyone. Somebody says thank you for the very beneficial talk and sharing. Okay, so I think that's the general feeling amongst our doctors. So thank you very much for your time, Mr. Sridhar, and thank you everyone for watching. We will end the broadcast now. Good night.
Good night. Stay safe.